So my name is Liz Kiernan. I know most of you, but for those of you who don't know me, I am the fellow who moved from Baltimore to Seattle and then back to Baltimore from Seattle and then back to Seattle from Baltimore. I'm not actually going to present on this topic, but I did have ChatGPT generate an image which kind of depicted my experience, and I think it's somewhat accurate. But I'm very happy to be back in Seattle. And what I'm actually going to present on today is a personal interest of mine, which is sort of a broad sweep into the endothelium and kidney health and disease. My objectives of the talk are going to be to start reviewing renal vasculature physiology and GFR, talk about the structure and function of the endothelium, to talk about endothelial pathophysiology and a couple of signaling mechanisms, and then to talk about the role of possible biomarkers and other therapeutics in endothelial injury. And finally, to talk a little bit about what the next steps for me are going to look like. So to get started, we should all ground ourselves in remembering why our organ is so special. And one of the reasons is that we know that the glomerulus is a unique vascular system, and it's a capillary bed that's flanked by two resistant vessels. And we know that the organ sort of is responsible for 20% of the cardiac output at any given time, 1 or 1.2 liters of blood per minute going through it. In addition to having these two resistance vessels, when the blood exits the efferent arteriole, it then descends into the medulla and then actually enters a second large capillary network within the cortex. And so this really represents two capillary networks in series, which is very unique to the body. And we know that there's really complex regulatory mechanisms that control perfusion both locally and regionally. And we love to pontificate and think about all of these mechanisms, and some of them are displayed here. So we'll start with renal autoregulation, which explains sort of the intrinsic ability of the kidney to regulate glomerular hydraulic pressure differences across a wide range of perfusion pressures. We also talk commonly about tubuloglomerular feedback, which is referring to the ability of the macula densa to sense changes to the composition of the tubular fluid and then cause afferent arterial constriction. And that really regulates to make sure that there's continuous solute and volume delivery in the distal nephron. We also love talking about the RAS system, and we know that changes in extracellular fluid, sodium, blood pressure all cause a series of enzymatic reactions that trigger Ang2 to be released and intense vasoconstriction at the efferent arteriole. And then finally, there's also this sort of paracrine interaction between the endothelium and smooth muscle cells, where changes in responses to things like flow and stress cause release of vasodilatory molecules, including prostaglandins and nitric oxide. So you may already be able to tell that I love physiology, and I think it's sometimes helpful to be able to ground ourselves in what is our North Star, which is the GFR, and sort of the mathematical forces that come together to contribute to this. So when you're calculating a single nephron GFR, you start with what's called hydraulic conductivity, and that refers to the resistance across the glomerular filtration barrier, which is composed really of three things, and it's the podocyte, foot processes, as well as the basement membrane, and then the capillary fenestrated endothelium. And importantly, the basement membrane is the largest contributor to resistance here. You then multiply that by the glomerular capillary surface area, which is actually the surface area for exchange across to Bowman's capsule. And then you multiply that by the difference between the hydraulic pressure of the glomerular capillary and Bowman's space. And it's worth noting that across the actual glomerular capillary, the pressure remains pretty consistent and always larger than the Bowman's space. And then that's multiplied by a constant, which is the sieving coefficient, which varies by macromolecule, but refers to the reflection coefficient across the membrane. And then finally, the oncotic pressure gradient. And this relates to a concept that's a little hard to grasp, but talks about filtration equilibrium. And this is the concept whereby you see that in the ideal nephron, the oncotic pressure in Bowman space is actually 0 because there's no protein there. And so across the glomerular capillary, as ultrafiltrate is released into the Bowman space, the oncotic pressure of the glomerular capillary actually goes up. So that's one of So that's when it all works, but pathophysiology is when everything stops working. And so how does this relate to what we see in daily life? Well, for hydraulic conductivity, we know that glomerular basement membrane hypertrophy, compromised endothelium, loss of glycocalyx will all cause impairment of hydraulic conductivity. Things like leaky vasculature, thrombosis, glomerular sclerosis will all cause us to lose surface area. And we know that persistent activation of things like RAS, endothelium, sympathetic tone will disrupt the normal hydraulic pressure balance. And then finally, we're very aware that when podocytes are injured and there's protein leakage, then we really interrupt the oncotic pressure balance. So now I'm going to shift to talk to you and try to convince you that the endothelium is really a dynamic organ in the body, and it's regulated and governed by a few important things. So in the quiescent state, there's first and foremost the presence of the glycocalyx, and this is a thick, negatively charged barrier composed of proteoglycans, glycosaminoglycans, and it sort of extends into the vascular space and then also into the fenestrated endothelium of the capillaries and anchors to the glomerular basement membrane, repelling negatively charged large things. There's also constitutive expression of thrombomodulin and other antithrombotic mediators when thrombomodulin interacts with thrombin and also protein C to sort of prevent coagulability locally. The endothelium is also dependent on having persistent laminar flow and shear stress, which induces endothelial nitric oxide to cause calcium flux into the vascular smooth muscle cells and cause vasodilation. And then finally, there's this concept of vascular integrity where there's sort of tight junction adhesions between the endothelial cells. And then the last thing I'll note is that, there's always this presence of adhesion molecules at endothelial cells, but they're usually actually buried within the glycocalyx so that there's not leukocyte adhesion and pro-inflammation. So then what happens when that gets disrupted? Well, the very first thing in response to cellular stresses, many different types of cellular stresses, complement cytokines, bacterial LPS, is that Weibel Palade bodies are released. And you may remember that Weibel Palade bodies are within endothelial cells and release von Willebrand factor, Ang2, P-selectin. And this change actually happens in just seconds. Then, after more persistent exposure to different molecules like TNF alpha, interferon gamma, hemolytic byproducts, that's when you start to get a real phenotypic transcriptional change, and the endothelial cells starts to generate more adhesion markers like VCAM, E-selectin, and there's also upregulation of this receptor type called proteinase activated receptors that bind thrombin and mediate inflammatory cytokine expression, complement deposition. And then importantly, you'll see featured here that there's also this kind of glycocalyx shedding. And then eventually, what we really fear is that there's going to be progression to this endothelial to mesenchymal transition. And this is historically best described in the cardiology literature, but gaining a lot of traction in mediating CKD. And most often, it's mediated by excessive TGF-beta signaling, which interacts via the SMAD receptor and causes this endothelial transdifferentiation. It's worth noting that other processes can also cause this, including endothelin and Wnt beta-catenin pathways. But what ends up happening is the cells undergo a phenotypic switch to a more fibroblastic type, expressing things like fibronectin and alpha smooth muscle actin. And the end process here is really that the capillaries undergo rarefaction and there's tissue hypoxia and tubular interstitial fibrosis. So a quick interval summary is that normally the endothelium is kept in a quiescent state, but then there's a series of reactions with activation, first with in seconds Weibel Palade release, and then a transcriptional change with a phenotypic change with type 2 activation, and then finally endothelial to mesenchymal transition. And I'm sure many of you are now wondering, what are some signaling mechanisms that dictate this? So let's start with explaining those, and we'll start with angiopoietins. So in the quiescent state, the main mediator of angiopoietin signaling is Ang1, and this binds to its cognate receptor Tie2. And this is really an important interaction for maintaining vascular integrity. The glycocalyx is preserved, there's no leukocyte adhesion, and there's an antithrombotic phenotype. But I already told you that when white blood bodies are released, then Ang2 becomes locally concentrated, and this outcompetes for Ang1. And when Ang2 binds its cognate Tie2 receptor, there's a rapid change where there's loss of glycocalyx, there's upregulation of cadherins, and then there's leukocyte adhesion and diapedesis, and a sort of a more prothrombotic phenotype. Next signaling mechanism I want to talk about is endothelium, which is having a bit of a moment right now, and I think it's important to think about the physiology. So endothelium 1 is actually expressed by almost all cells within the kidney, and really where the physiology matters is by what receptor it's bound to. So the endothelium A receptor is expressed on smooth muscle cells, and this mediates really aggressive vasoconstriction of the efferent arteriole. It promotes reactive oxygen species formation and endothelial dysfunction with persistent signaling. And then it also stimulates mesangial proliferation, which is part of why it's important in IgA nephropathy. And it can also mediate podocyte injury and activate heparinase that degrades glycocalyx. Endothelium B, on the other hand, is expressed on endothelial cells, and it actually is more important in the sort of peritubular capillaries and mediates vasodilation and nitric oxide release and causes natriuresis and diuresis in the renal tubule. And there's this really beautiful review article. This figure kind of summarizes a lot of those different effects, and you can see how there's constriction, mesangial proliferation, glycocalyx breakdown, podocyte breakdown. So it's really a dynamic signaling pathway. Finally, I'll talk about VEGF, which is important for all those interested in angiogenesis and diabetes. And in the kidney specifically, VEGF is actually released by podocytes, and it binds to receptors on the endothelial cells, which are the VEGFR2 receptors. And this is a really important interaction for paracrine signaling because there's actually a survival factor for endothelial cells. And it's really held in a close balance because too high of VEGF will promote neovascularization and destruction and injury to the GBM, whereas low VEGF will cause endothelial cell damage and eventually loss of podocytes. And we really see this play out in diabetic kidney disease, which is quite interesting. So hyperglycemia actually stimulates VEGF secretion locally at the podocytes, and this causes early angiogenesis and leukocyte adhesion and an inflammatory switch within early DKD biopsies. But then as diabetes advances and we know that we lose podocytes, then you end up having much lower VEGF locally, and that leads to capillary loss and fibrosis. So if I haven't overwhelmed you enough, please know that this was only the tip of the iceberg with endothelial cell heterogeneity. And there's this really interesting new body of research which sort of talks about how endothelial cells are very distinct based on where they are locally and also the sort of microenvironment that they're exposed to. So things like high osmolality, very low oxygen tension, and then also just the anatomic localization of endothelial cells causes them all to have sort of a unique transcriptional signature. And there's a really interesting new body of evidence looking into sort of the way that these cells can be studied to understand mechanism and progression of disease. But before I leave that topic, I just want to make sure I point out that the majority of this talk so far has talked about glomerular endothelial cells, but it's worth noting that you can separate endothelial cells based on glomerulus or peritubular. And peritubular are really quite distinct cells. They have a much thinner glycocalyx and stroma, and they're really specialized for having high metabolic absorption and particularly high glucose absorption, and also to exist in a sort of a low oxygen tension state. And they really have this important coexistence with cells called pericytes that wrap around the peritubular capillaries and are very, very important in mediating survival and also local regulation of blood flow in response to sympathetic tone and a lot of other sort of local signaling factors. Okay, so I've been talking for a long time and you might have forgotten why you're supposed to care. So we're going to go back to the GFR. And I'm going to try to convince you that the endothelium does affect some of these things. So we talked about how there's loss of glycocalyx and dysfunction of endothelium and podocyte interactions, and that can disrupt hydraulic conductivity. Things like leukocyte invasion, complement deposition, hypercoagulability, and scarring can all lead to loss of surface area. We've seen that endothelium and RAS constriction and apoptosis will disrupt the hydraulic pressure gradients. And of course, when you have increased permeability and podocyte loss, then you're going to have loss of sort of that oncotic pressure gradient across the glomerular capillary and Bowman space. But also many of us are clinicians, and so I want to talk about the relevance of this with actual disease states. And it's worth noting before I say this that the endothelium is quite relevant to many disease states that I won't talk about here, like antibody-mediated rejection, ANCA vasculitis, lupus nephritis. But for the purposes of this, I'm going to talk about things that we see almost every day. So first, starting with sepsis. So it's very well described that exposure to LPS in animal models and sepsis in humans causes this characteristic upregulation of Ang2, VEGF, and endothelin-1. And similarly, upregulation of these adhesion molecules that's associated with disease severity. Moving to diabetic kidney disease, there's many different cellular pathways that mediate this, but there's sort of this characteristic increased permeability and apoptosis of glomerular endothelial cells, especially in response to reactive oxidative species. And there's loss of glycocalyx and albuminuria. And then with chronic kidney disease, there's also this sort of a theme that there's elevated soluble adhesion markers. And interestingly, there's these findings that certain uremic compounds, specifically indolic compounds, actually directly inhibit endothelial proliferation and decrease nitric oxide production and promote leukocyte adhesion. And eventually, this can lead to the sort of endothelial to mesenchymal transition that I talked about. So let's actually get into sort of how we can clinically apply this. And I'll start with sepsis-associated AKI. So we talked a lot about Ang2, and it's long been known that Ang2 levels are associated with AKI severity and sepsis. And this has been shown in many cohorts. This is a paper from Critical Care in 2021 in an ICU cohort. And, we've seen also that ratios of Ang1 to Ang2 can have implications for mortality. So this is a paper that looked at the Assess AKI cohort, and it showed that having a very low Ang1 to Ang2 ratio was associated with higher rates of death, and that AKI status really significantly modifies this effect. And then I just want to share some of the work that I've been lucky enough to be a part of. So we looked at the Clovers analysis last year, and the Clovers analysis, just by way of review, it was a study published in New England Journal in 2023 looking at patients with sepsis-associated hypotension, and they were randomized to either early restrictive fluids and then early vasopressors or liberal fluids for their sepsis-induced hypotension. And the overall outcome of the trial was that there was no difference between the two groups. So being able to work with Leela Zelenik and Pavan Baraju, I was able to sort of apply subphenotypes to these groups, to the study population in Clovers. And we looked at Ang2 to Ang1 ratio in TNFR1, and we were able to separate into two groups where a high Ang2 to Ang1 in TNFR1 was denoted as what's called SP2, which was sort of this endothelial inflammatory phenotype. And then the opposite was SP1. And what we saw is that these groups actually separated very distinctly by way of clinical outcomes, with the endothelial inflammatory group showing a lot worse outcomes. And we were also able to demonstrate, which is shown in this figure here, a treatment effect where restrictive fluids was specifically beneficial on mortality for those with this subphenotype of endothelial injury. Okay, moving on to some of the other medications that we use very commonly. So we use SGLT2s all the time in diabetic kidney disease. So is there any evidence to support that it may affect the endothelium and protect the endothelium? Well, in preclinical models, definitely. So preclinical models have been shown that SGLT2s decrease reactive oxidation species, increase endothelial nitric oxide concentration by changing some of the nitric oxide synthase enzymes. They also cause a reduction in these increased adhesion molecules. And then finally, they mediate several changes and changes in mitochondrial metabolism that decrease the endothelial apoptosis and endothelial to mesenchymal transition. And I want to focus in on one very interesting study that was published in 2022 that really highlights the way SGLT2s can affect the endothelium. So this group looked at mice that had obesity and diabetes and then treated with and without empagliflozin. And in this first panel here, you can see that there's this loss of capillary density in the diabetic glomerulus, and that empagliflozin is able to recover this moderately. So the authors asked themselves, so is this from recovery of the podocyte damage or the capillary architecture? And what they found is that the podocyte structural damage actually doesn't change at all with empagliflozin, but what really changes is the capillary architecture. So they were able to show in transmission of electron microscopy that there's this big change in sort of the amount of porosity within the endothelium. And specifically, they see upregulation of a protein called caveolin, which functions to form bridging diaphragms within the capillary endothelium. And empagliflozin is sort of able to sort of normalize those levels of caveolin, and it's pretty dramatic effect. Authors further wondered how this was mediated, and there's this known association where high VEGF locally in early diabetes is known to upregulate this caveolin protein. And so they sort of offered this model that I found pretty interesting whereby they say that in early diabetes, there's upregulation of VEGF, and this causes this increase in these caveolin expression and increased porosity of the endothelium. And SGLT2s actually act by reducing VEGF and then therefore reducing that dysfunction of the paracrine interactions between podocytes and endothelial cells. Okay, but moving to the next drug, I think this is probably one of the more interesting drugs, which is endothelin receptor antagonists in diabetic and chronic kidney disease. So we'll first review the physiology, which is that endothelin A receptors cause vasoconstriction and cell proliferation, whereas endothelin B receptors cause this vasodilation and natriuresis in the tubules. And some people may remember that there was this kind of pivotal trial of an endothelin receptor antagonist in 2010, and this was using a drug called avosentan, which had primarily selectivity for the endothelin A receptor, which is thought to mediate most disease. And what they did is they took patients with type 2 diabetes and CKD, and they randomized them to drug or to placebo or two different doses of drug. And interestingly, this trial actually showed that there was a worsening of eGFR with the drug relative to placebo, but they did show that there was a pretty dramatic reduction in albuminuria. But the trial was stopped early at something about 4 months, and this is because of dramatically increased serious adverse events in the drug group, which were mostly driven by fluid overload. But folks have remained persistent, and there has been this new sort of barrage of endothelin receptor antagonists and kind of a renaissance of these drugs in clinical medicine recently. And so I want to focus on this drug called atrasentan, which was first published in a smaller short-term trial called RADAR, demonstrating sort of a better safety profile than avosentan. But this, you can see, has a much higher endothelin A selectivity. And it was studied sort of more extensively in this trial called SONAR, published in Lancet in 2019. And what they did was sort of an interesting trial design where they screened and randomized many, many people with type 2 diabetes and CKD. And then they did a run-in period where they actually looked for enrichment. So everybody who was enrolled got trial drug for about 6 weeks. And then they used a pre-specified outcome of urine albumin reduction greater than 30% to qualify people as responders versus non-responders. And then after that run-in period, everyone who tolerated the drug and responders and non-responders were included in the double blinding. And what they found there, so it was a event, the trial was designed for event rates, and the primary outcome was worsening of chronic kidney disease, ESKD, transplant. And they did see a protective effect with about 6% of the primary outcome being reached with the drug and about 8% in placebo, with a hazard ratio of 0.65 favoring atrasentan. And interestingly, when they included both the responders and non-responders in their analysis, they still see this protective effect with a hazard ratio of about 0.75. However, they did show that there was still increased rates of serious adverse events, with primarily that being driven by fluid retention and anemia. But it's not over yet. And so curious and inspired investigators, after reading SONAR, wondered whether or not they could mitigate these adverse effects from these ERA drugs. And in order to do so, they thought about how they could combine it with some other agents. And so specifically, the Zenith CKD trial investigators looked at the combination of dapagliflozin with another ERA called zibotentan. And when they looked at markers of fluid retention, including bioimpedance measured extracellular fluid change, weight change, and BNP, they actually showed that the combination of therapy is able to sort of protect from some of these adverse effects. And they published their sort of short-term results, which are just their urinary albumin outcomes, and do show a positive result that the additive effect of SGLT2s with these ERAs may be more protective than SGLT2s alone. There is an ongoing trial which will look at sort of the outcomes of CKD progression called Zenith high proteinuria, and the results are to be determined. So perhaps there's reason to be inspired. We talked about all of these issues, and we talked about how Ang2 might be a biomarker to understand some of this disease process. SGLT2s can interfere with leukocyte invasion, increase permeability in this VEGF disrupted signaling. I didn't show the data, but GLP-1s may also reduce some of this local inflammation. And then finally, there may still be a role for ERAs. So in closing, I'll talk about next steps. And when I think about what I want to do next, I think about the words of wisdom that have been shared with me at the University of Washington. And this is that cops lie, doctors lie, patients lie, everyone lies, but the urine never lies. And this quote is ascribed to Pat Fleet, who said something to that effect. So what do I want to study? So I want to look at the urine, and specifically I want to look at urine proteomics and AKI. And to do this, I'll be looking at patients from the Kidney Precision Medicine Project and defining AKI as sort of an improvement in serum creatinine at 72 hours from peak, using pre-specified outcomes. And this separates people into two groups. And I'll look at the urine, and we've generated proteomics from the urine using Olink. And then simultaneously, I'd like to look at sort of the transcriptional differences using single-cell RNA sequencing between these two cohorts. And one of the hypotheses I have is that non-resolving AKI will demonstrate a urine proteomic and transcriptional signature that's enriched for pathways of endothelial damage and inflammation. So to conclude, the endothelium is a highly dynamic organ. I hope I've convinced you that activation and signaling can lead to progression of kidney disease with myriad different effects, that perhaps we can use biomarkers to enable clinical trial enrichment and help with targeted therapies, and that more research on the mechanism and prevention of endothelial disruption is warranted. And I will thank my research mentors, who are Ian DeBoer and Pavan Raju, as well as Dr. Leela Zelnick. And I also get a lot of great tips from people like Simon and Christine and Justin and everyone else at the KRI. And of course, thank you to the fellowship, Yoshio, Carrie, Fanula, Raj, of course, Danielle, and all of my co-fellows, old and new. So I will stop there.
Very nice, Liz. Thank you so much for that all-encompassing talk there. Well, we have just a few moments, maybe for one or two questions or comments. Anyone has any? Lots of applause.
Yeah, Liz, that was a fantastic talk, a great overview, and really nice tying it into the clinical side of things. I know there's some new angiotensin 2 inhibitors being developed. I'm just not aware of anything being done in the kidney world with these. Did you come across any kidney work on Ang2 inhibitors?
Angiopoietin 2 or Ang2? Angiotensin 2.
Yeah, angiopoietin 2.
I do know that Susan Croghan published in JSON, and there's companies that have small molecule inhibitors that are looking into it. But I don't know if Pavan or someone else might know about ongoing clinical trials, but I know that there are some companies with interest in direct inhibition.
I was just curious, you mentioned earlier in the talk about different endothelium phenotypes and their response to SGLT2 inhibitor therapies. Do we currently have available ways to, commercially available ways to test these phenotypes and know which patients may benefit most from these therapies and those who would not?
Yeah, I think that's sort of a hope to move for the future. I think there's some hope that blood biomarkers will be able to understand that. So that was, I think, what was pretty exciting about some of the work I got to do with Pavan and Leela, looking at Ang2 in the blood and seeing that there's a specific benefit for high Ang2 phenotype with using early vasopressors in sepsis. And I think as sort of the understanding of these different phenotypes and more single cell work is done, that hopefully they'll be able to be used for trial enrichment and kind of understanding precision medicine.
Okay. All right. Well, any other questions or comments for Liz? All right. Well, thank you so much, Liz, for that wonderful talk.